cardiovascular disease is really important, but there's just an overwhelming ability to go beyond the many other chronic conditions. You talk about smoking cessation, of course, lung disease, and we talked about the gentleman who had stage 4. I mean, there's all sorts of other sort of opportunities that could arise in doing things like this. So to answer your question, Bill, we're a small IPA in Sutter, but I think our real interest is really finding ways of solutions like this, and that if there's an opportunity to have a conversation, the real question is where is the forum to have that conversation, to carry this on, because it's about sustainability. Whoever said that over there, it's about sustainability of the idea, continuing this and continuing the meetings, and continuing the discussions to eventually come up with something that an ember that later on becomes a spark, that becomes a fire. Maybe I shouldn't talk about fires. A real fire to really get this going.
So we did meet with the president of the foundation here at Sierra Health. He's very sorry that he is not able to be here himself today, but we brought him your book and your National Geographic, several of our leaders, Bill leading the charge with Joe Sky, and he was so excited about it. And he said that, yes, introduce the topic here, but then let's have a full day completely dedicated to this, where he brings in the community leaders, because he knows those community leaders. We just work in the healthcare sector, which is a very, very important sector, but it's that 20% of the equation. So we also have, we'd like to hear commentary from some of our other partners that are on the agenda. Dr. Kimberly Buss, who's the head of population health for Sutter Medical Group, and these medical groups are affiliated, but they're sort of, well, you could describe it.
So thank you, having asked me to be on this panel up here today, and so thank you very much. This is really exciting to be here, and I've actually been a member of the health community here in Sacramento since I started medical school at UC Davis. So very long-standing member, 24 or 5 years here in the health and community. And listening to what you talk about, I do think in a lot of ways we are right as a city for this sort of work. So much of the foundation has been laid. There's so much activism. We have a lot of strong faith-based communities here that are extremely involved in being collaborative with each other and also in supporting the community. A couple of things that I also think we have as strength is 4 large health systems that are each themselves doing really well, between Sutter, Mercy, and Kaiser, and UC Davis, and all extremely active. But I have recently got involved with the California Academy of Family Practice, and as I've gotten involved with them, one of the things that just comes out repeatedly to me is kind of the gap we have with healthcare for our safety net populations. So we have like a lot of the population with excellent healthcare, and you see their fantastic results, but then we have a large portion of the population with, it seems like extreme gaps in healthcare, and probably not getting anywhere near the results. So I think that would be a big barrier and challenge for us to come up with solutions to that, and would require a lot of giving on the part of the people who are doing well to the areas that aren't. And the other thing that, just as a question that I think we really need to answer as we go through and think about what the options would be for Sacramento is how much is Sacramento already doing well? I mean, we know Sacramento has just had well, personally I'm super proud of it, having lived here for all this time, but when I think back to when I moved here 25 years ago and what we are as a city today is so profoundly different. And if you would think, where is a city with great opportunity, to some degree, we've already, I think, accomplished so much. I don't know how much kind of more opportunity there is, perhaps a lot, but I know there are tremendous numbers of people who are working so hard on this work already. I don't know where the gaps are in our healthcare. When we look at all these health systems with all these fabulous results and all these excellent blood pressure controls, but yet then we still have such poor outcomes. Where is that gap?
But that is only recently won ground. So that was hard fought, and that was your hard work, Jose's hard work, Bill's hard work. When we started here, those numbers were horrible. So let's just give some credit to the very large strides that have been made, huge amount of leadership fellowship that's been contributed. And we have a new leader on the scene that I would like to hand the microphone to, and that's Dr. Neil Kohatsu, who is now unbridled from having been working in senior positions in state government since he left his preventive cardiology fellowship at Stanford. He is now in population health at UC Davis, and he can bring a lot of muscle to this issue. So thank you, Neil, for being on our technical expert group for decades now and helping every way you could quietly.
Hattie, thanks so much, and I think it's so exciting that we're talking about blue zones and this power of community. My own background's in preventive medicine, so it's very close to my heart. And I think one of the strengths of the Power 9 and just the observations that you shared was that it isn't disease focused. And I think we have to look at some of the training in epidemiology as well as Hattie noted at Stanford, cardiovascular disease epidemiology, and grew up learning about the Minnesota Heart Health Project, which you're probably familiar with, Pawtucket Heart Health Project, Stanford Five Cities Project, Stanford Three Communities Project, all focused on heart disease, by the way, community-based, but they could hardly keep up with the secular trend in San Luis Obispo, talking about the Five Cities Project. And I think one of the strengths, which we'll get to a question I had about blue zones, is it's not disease focused, it's not even risk factor focused. I think the emphasis on social connection, quality of life. My colleague who had to leave early for a medical appointment is PI on a project that I'm working on based on a whole health program, similar to this, building micro-communities, resilience, as well as targeting weight reduction is really much more also about sleep and social connection and empowerment and all those things that you talk about. So it's a long introduction to the question, which is, as you work through all these communities, I think one of the things is finding the leaders in the community, whether it's a small town or a big city like Fort Worth. And rather than focusing, because I think we will get to cardiovascular disease improvements when we address the diet, when we address physical activity, how do you engage and get communities to buy in? Because each community is different relative to the Power 9 or any other engagements. One community may be about smoking cessation, but people are worried about opioids, worried about sexual violence, they're worried about a million other things, they're worried about climate change, they're worried about forest fires. And if you focus in on one thing, then you can say, well, I'm focused on that. Maybe you could talk about how you engage any community so that we ultimately, I think we will benefit heart disease, cancer, diabetes, and many other things.
Thank you. Thank you for the question. Thank you for your work. And I just found out that my brother Dan will be the governor
tomorrow. Yeah,
So,
they're bringing up blue zones.
interested in looking up blue zones for.
And I was thinking, did you guys travel together?
No,
Oh,
we,
okay.
we never do. We cross paths.
Oh.
So
Okay.
when we started in Albert Lee, I don't think we even knew what would happen. But it caught on fire, and then to go to big cities and do a population of 100,000 plus, and then take the same model into a city of 1 million plus, and now even out of the country, where their healthcare situation doesn't even benefit getting people. You know, in Canada, in the EAU, and in New Zealand, we're receiving about 1 million hits a quarter on our website and over 120 inbounds a month of communities that want to partner with. We simply don't have the bandwidth to handle that right now. We're looking for the right partners. The right partners, we know that this cannot be done in silos. If this is about me, then we're not interested. If this is about we, because these are community-led initiatives, we're not going to come in and tell you all what to do. You know your community better than we do. You understand what assets and what's working and what the barriers and ongoing challenges are, what our proven approach and the rigor and the measure, the programming, experts, and the system that we set up will do in the front end is determine, are you ready? If your community is not ready, we simply won't work with the community. It's a waste of your time and it's a waste of our time. So we've done this now, as Ben said, going on 53 times, to where we'll bring our national team and our experts in, and we're watching how the community shows up. We're providing the guidance and the training and the tools and the media and the PR and the marketing, the list of whom, understanding your community better, and we're coming in to just have the conversation to understand, so that we can start to understand what your priorities are. What would the objectives and strategies, the actual activities and the measurement and the ownership look like? But the front end is just engaged communities. As you know, there's communities around the country that aren't even thinking about something like this. It's not even a priority. They will be at some point, because what we're going through is not sustainable. Other communities that are doing great work, as you mentioned, we hear it a lot. We seem to be ripe for this right now. We've struggled for decades. I'm not saying that Sacramento has, but I hear from you. We've put the coalitions, we're practiced, we're ready. We've taken it more or less as far as we can. We want to do better, as we've heard in some of the communities with the highest well-being in the country that are blue zones. They understand there's more work to be done. So it's that coming in and teaching and learning, so people don't understand that they're not threatened by a collaboration, that they understand it's about choice and evidence-based, and it's your community and it's measurable, and how we go about that is how we choose the partners that we move forward.
So just one comment relating to that. In our formative research, we focus groups in Sacramento across the state from Medi-Cal. Sorry. Just one comment. We, part of our formative research for this study that we're doing, we did focus groups across the state. Medi-Cal moms is the target group on Medicaid. And the number one health concern, if you will, that they talked about was social connection. They said, remember when we used to have block parties? More than anything else, access to health care. There are a lot of needs, housing, jobs, education, and those were lower ranked. And I think particularly at this time, this notion, which is such a strength of all the communities, is that there's a strong social cohesion that can be built back up if the community wants to do that. So I just wanted to
That's right.
say
What I hear, when I started this work in communities, 9 years ago, I was part of the team that started to set them up and all the learning and mistakes we made. What I continually hear when we go in to do our certification audits at the end of the first phase of the district transformation is that the Blue Zone project itself allowed us to get done in a year what used to take 10 years. We didn't create any magic wand. That was them just prioritizing and then wrapping them accountability. That's right. That's exactly right.
My studies, my daughter's in
That's,
biology.
and the other point I hear from community steering committees and sponsors is the Blue Zone project, because of the connection to the longest lived populations, to National Geographic, to New York Times, to other community members that have been in Blue Zone communities or traveled to Blue Zone area, that it brings out people that you simply never see in the healthcare conversation. And I think it's that critical mass, that ownership of the community, and that catalyst that provides us the growth that we're experiencing.
Yeah, thank you so much. This is Javier Lopez. I'm a cardiologist in UC Davis and medical director of cardiac rehab at UC Davis. So I have a comment and a question. So the first comment is that at UC Davis we have some evidence that what you're describing can be created in the health system and it works without building any structure in the city, obviously. But about 15 years ago, UC Davis had a program where people came together in community. So with cardiovascular risk factors, they had one cardiovascular events. And the program, they met 2 or 3 hours a day, 5 days a week. They cooked together, they ate together, they plant-based, they exercised together, created a community. They're bound for 2 years. And the outcomes are amazing how 20 years later, there's almost 1 1.5% risk event when people bound together, people that disbound because it was not a obligatory thing to stay in the program, their rates goes up as they fall apart from the group. But the group that stayed together had remarkable lack of events. And the concept was community, eating together, exercising together, and obviously addressing risk factors and educational components around risk factors. So this kind of process can be created in this very small micro environment and or around the city. So it's exciting. My question is, because we talked about the success stories, how many have been finished? Stories, how many cities you've done to and things fell apart? What are the lessons learned from those that did not work out?
Yeah, I'll start and then hand it to you. What I can happily say is every single community that we chose continues to do the work. Be it Blue Zone Project Phase 1, Phase 2, or we even have communities in Phase 3. So that tells us that the work that we're doing as a partnership is working and people want to continue. There's one of our projects that are no longer under the Blue Zone brand, but in the communities that were started, they continue to do the work that the foundation work set up. And so it's about spending the time to do the rigor on the front end to make sure there's readiness. And to have people put their pen to paper and say, I understand the success of this project is going to lie within the rigor of my leadership. We know that the grassroots efforts, there's things going on and they can be ignited. It's those leaders that are going to be making the tough policy projects and programming decisions. They're going to need the support, and that's why we create that perfect. If there's one piece in there that isn't aligned, we know this won't work, and we'll just move past and go. And I'll leave it.
I would say for the scientists in the group, we've been able to replicate treatment effect, impact, and I would still say what's at bay is if you were to measure intent to treat, with those same set interventions, is there's a big space still yet to be conquered, even within the construct of the projects that we're doing. I would tell you that this is based on epidemiologic theory, that a lot of small interventions across the whole population, we're betting have a greater impact in a really deep, intensive intervention to a much narrow slice of population. It doesn't mean those have to be mutually exclusive. In fact, I have to believe that if you can combine those two approaches, that you actually have a chance to do what I call all population health, not the small population health that typically gets confused. And I would tell you, with our North Star metric, which is measuring improvement in overall well-being, as well as out of the different 80 inventory items within that survey, setting a bar and a criteria of moving 30 of those indicators in a statistically significant way, not only in comparison to baseline, but also in comparison to matched population cohorts in a way to be able to look at trended analysis as well. We've been successful in moving the needle on well-being in all of the work that we've done, but that doesn't mean that we haven't failed inside of every single one of those projects. I mean, if we're doing this right, and Dan Buechner thinks of this basket of things we do in a Blue Zone project as kind of not silver bullet, but silver buckshot. So that pellet pattern, we keep trying to engineer and re-engineer and keep in the things that we know consistently have shown to kind of be replicable and applicable no matter where we go, finding the part of that pellet pattern that's not causing an effect, and then trying to introduce new things to it. So with every project, we ask communities to be willing to be innovators with us around something really unique to their community. It'd be no different here in Sacramento, and to be able to identify a way that to that armament and that portfolio of Blue Zone's intervention work that we can add to the evidence base as we go and then share that with all the communities where we've been and where we might go in the future. So we are not perfect. To Tony's point, guys, this is like a new model that's been tried for a decade. And we've been incredibly passionate and persistent about this work with belief. It's a belief model that this can and does work. And then we've not asked people to trust us. We rigorously measured this, and I know there was the research question. You know, we would invite top researchers, top measures of important indicators in this community to the process in helping building out the blueprint and how that would get measured. It's not just Blue Zones comes in, does work with you, asks Gallup as a partner to measure, and then tells you how great it was. You know, part of getting a Blue Zone success is tracking metrics, which you guys are all filled with metrics here, which is so exciting to see. Continuing those measurements, because all of those ought to get lift as a part of what we're talking about, and introducing new measures that you would expect to see or you wish were being measured, and this becomes you know, the catalyst to create a next dimension of measurement that holds it accountable. So this is a call it value-based, call it an accountable community health design. When Blue Zone projects comes in, we do get paid our fees to do this, but our fees are put at risk for the annual progression of a dashboard of metrics from baseline that are improved, that include your measurements as well as our measurements in the mix. We don't think there's anything like that out there as a business structure for facing into this type of work.
We're going to cap the questions just now because we want to get please ask after the program. We'll be happy to do that. Two announcements at the end of the program today. We will have a MOI reception outside the door here for any of you who want to live longer. Join that MOI outside, and we'll encourage you to live longer with that. We're going to conclude with Betsy, who started us out with her healthcare challenges and vision, and she's going to conclude the program today. Before we do that, I want you to know, I just texted the Folsom Dam gate operators. I asked them to open all the floodgates. You will be in a Blue Zone in about 20 minutes, so Betsy has 20 minutes to talk. Betsy.
Thanks. What Bill didn't say is not only is the MOI going to help you live longer, the Sardinian wine that was imported that will help us all live longer. What a fantastic way to wrap up the day. I'm so excited that you all had a chance to come. I've known of your work but never heard you talk about it, and I can tell that you've captivated folks and kept us all engaged and excited, which can be hard to do this late in the day. And I do want to clarify, because I can't remember who, Joe Sky, that said that I said no more R&D is needed. Well, and that is what I said in relation to what we need to do to achieve decent hypertension control, because we aren't covering just the basics right now as well as we can. But I don't want anyone to think for a minute that, one, I don't want to see more innovation, but two, I would love to see us all upstream, and not talking about hypertension control or statin management, and really preventing all of those conditions in the first place. So this work is very exciting for me to hear about as well. But for now, my focus is on sort of where I have a locus of control, or at least a little teeny smidgen of control. And that's why I will keep hammering away at hypertension control. I did want to come back and just sort of say a few themes that I heard throughout the day, and there were many. There were sort of very high level, more sort of the smaller, 5,000 foot level. There was a lot of talk about electronic health information. And full disclosure, some of you know this about me. I was sort of the person responsible from the CMS side of being linking with professional organizations in this region of the country to roll out a meaningful use program. And we all, we can say what we want, but I think in the end, there's still much work to be done to meaningfully use electronic health information. It is a necessary but insufficient condition of getting us where we need to be. The burden on physicians and clinical staff of using the EHR has to stop. It has to be dramatically reduced. There are several studies showing that physicians spend more time in front of their computer screen than face-to-face with the patient now. I think it's 4.9 hours to be somewhat precise. So someone kind of mentioned a comment about electronic health information where care happens. I don't think that's what they really meant to say exactly, because that is not where care should be happening. And there's a lot of models out there that are being tested and somewhat very promising to reduce that EHR burden, but we have to also get to true interoperability, which several of you mentioned as well. There was also talk about it, and this is somewhat related because it's about clinical support. There's increasing evidence, as I mentioned, for self-measured blood pressure monitoring, but you can't have patients coming in with their handwritten logs. That has to be with the clinical support and fed directly into the electronic health system. We will get there, but it has been very painful. I mean, we're only 10 years into this, not quite, but you know, there's still going to be a little bit more pain. And then the last thing I heard, not maybe this word, but is about alignment of incentives, of payment, of the metrics, of the outcomes we want to see, and across all sectors. And I was so glad to end on this very broad, not even a healthcare sector discussion really, because that's where I've been headed increasingly, that it's not just the health sector. It's not even just health and transportation and housing. It really is about community. So I will stop there. I'm supposed to say one other thing, which is the award winners are supposed to come up here and have their pictures taken immediately after the session. And I think Steve Shortell's going to have the last word.
So really, this is going to be the last word, promise. Just a couple of things. Please fill these out if you haven't already. Just turn them around there in terms of commitment. And kind of building on Neil's comment earlier and the importance that our Blue Zone colleagues have indicated around readiness, right? So one suggestion, Neil, and you've seen it and others in the room I'm sure as well, when you think about community building and you're going in with a program like this, to really assess the current flow, In other words, what are the good things happening in Sacramento now? What are the strategic agendas of the various organizations and leaders in Sacramento? And try to go with the flow and embed within that instead of trying to counter the flow or go against it, okay? Because that just doesn't work. So that's part of the readiness assessment. So I would just underscore that. And the only other thing I think I want to say at this point is, are any of you going to do anything different tomorrow? You're going to go to a meeting as a result of what you've heard today? And what are the blue zones in your own organizations, in your own communities? Many of you are from Sacramento. Some of us are from People's Republic of Berkeley and other kinds of places, right? But to think of it that way also. And finally, I will say we want the award winners up here. But on the way out, I don't know where religion is these days either, but Hattie said she's going to station a couple of ushers, and we're going to get your first donations to the Sacramento Blue Zone on the way out.